So good morning, everyone. This is a 52nd session and 2445 cumulative session from Heartcare Foundation of India. This is a doctor's meet of NDB DMA IMA meet. I would like to invite my team member, Dr. Meenakshi, to take this session. Dr. KK Agarwal is not available for this session. He's keeping well, he's fine, he's stable, and we would see him in the next session. Over to you, Dr. Meenakshi, to introduce the speaker and to take this show forward.
Thank you, Saurabh sir, for continuing these sessions even when sir is resting quite well. Today we have among us Dr. Nidhi, who's the Associate Medical Director ENT at Shroffs Daryaganj, and she's been with us for the past 1 year, and we've all been here listening to her, the research that she talks to us about, and all the input that she has. And today she has actually prepared something for us to talk about the current scenario, which is quite abysmal in my opinion. But let's hear from Dr. Nidhi what she has to say about the current pandemic situation in the country. Over to Dr. Nidhi.
Thank you so much, Dr. Meenakshi, and thank you, Saurabh. It is reassuring that Sir is well, and he sounded very strong when today he called me in the morning and said, you have to take the session today. So this is a very, very basic overview of the situation as I see it. We cannot match the scientific inputs that Sir has and how he conducts these sessions, but let us just go through the present scenario and see if there is a ray of hope for us, which I am sure we all want to see. So here it is. If we look at, this is as of 1st of May, Eastern time, 8:15. That means this is from the US. They have collected this data. As of 1st of May, the new cases seem to be showing a little dip. Too soon to tell. We have seen that we have gotten reassured too soon in the past also. But if this is so, it is a sigh of relief and a breather for all of us. In Delhi also, if you look at it, the graphs recoveries are showing an upward trend, and the active cases and the confirmed cases are somewhat going down. What is of note is that in Delhi, the test positivity ratio is still higher than 30, which is of great concern. We need to bring it down to less than 5 if we have to open up the lockdowns, according to WHO. And we haven't really gone into a lockdown this time. This is for the entire country. We seem to be kind of plateauing out. The active cases seem to be going down. Recoveries seem to be going up, which is all a good trend. So the test positivity being high is an indicator of high caseload and the high transmission rate. It will become low either when the transmission goes down or the loads are low, or if the test numbers are high, if you're testing more and less are testing positive. So we really have to come to the point where we are doing enough tests and being reassured that it is not in the population, which right now looks like a fire outside. If we look at how things have panned out across the world, Israel has practically 0 new infections, and they have crossed 60% of the population being vaccinated. And this is both doses. This is not single dose. UK has reached about 50% threshold. If we look at India, it's way down there around 10%. Even our 10% is more than Israel's total. So we have done a very good job doing the vaccinations in sheer numbers, but our numbers are so high that we haven't reached the threshold for protection of the community. So if you look at it, the total number of vaccines given in India has been 152 million. And in US, it has been 240 million. The other countries are way down there in absolute numbers. But in terms of percentage of population, we haven't even reached 10%. And this is what is possibly driving the present strains. I think we need to deal with vaccine hesitancy. We have to be a little proactive, a little smart, and of course, be very careful when we vaccinate, because there are other things that we are now noticing with vaccination, but we have to encourage vaccine uptake as much as possible. If we look at these countries, these are deaths more than the expected deaths in the last year. And if you look at it, Turkey, it has those peaks. South Africa, Spain, UK, the red line is actual deaths. In Mumbai, we don't have complete data, but if you look, there is that peak that happened around March to June last year. So these countries have all shown significantly higher deaths than was expected from the usual. And look at these countries. Their death rate has actually gone down. Japan, Germany, Norway, Denmark, they have gone below their expected death rates because they brought in very serious control measures. Wherever they found the outbreak, they isolated the area. So it was not just individual isolations, it was actually area separations and quarantine guidelines. These are just single dose vaccinations. So if we look at this, India is 120 million and US is 140 million. The rest of the countries are all way down there. However, their percentage population is much higher. Now, this is something that Sir has been really emphasizing on, and I think we need to make this graph almost, I think, Ritu, if you can put it on our groups and we are able to share it. Going for antivirals or remdesivir or plasma in the late stage of disease where it is the immune dysregulation phase is really not helping. I think we should be clear of what is really the COVID syndrome. In the first week or so, we are seeing the replicative phase of the virus. That is where all those antiviral treatments might work if you have a high risk person and you have crossed the 7th day. Giving an antiviral is not adding to outcomes. It's from the 7th day to around the 14th day, the viral debris and the dead viral particles are flooding the system, and that's where the immune dysregulation is coming into play. And around the 14th day onward, but I would say around the 10th day onward, as we are seeing in the chemistry, the thrombotic complications start to set in. So early steroids around, say, the 3rd to 5th day, if you're seeing signs of pneumonia, early blood thinners, early, we have to start attacking the immune dysregulation rather than thinking that it is the virus which is causing the havoc. The virus dies out after the first 5 to 6 days. And this is a study done at the NHS hospitals, which has found the effect of dexamethasone. So dexamethasone not just reduces the severity of disease, but it also reduces the need for mechanical ventilation. If you look at the first graph, that is the red graph is with dexamethasone, and the black graph is with the usual care. If you have only oxygen, even there the dexamethasone is helping. Remdesivir is not adding to the outcomes. So I think we can now have this open to discussion.
Thank you, Dr. Nidhi, for that, this illustration. It was a much needed reminder. I think all of us just want to switch off the TV now, and especially when the news is running, we don't want to hear any of it. But that was a very beautifully put and put together. Uh, we have all our doctors here. If there's anything that they would like to say, Dr. Ashrani.
Hello, good morning. Wonderful presentation, and my concern and from all of you and from by and large the doctors in Delhi, our concern for Dr. K.K. Agarwal and his recovery, faster recovery. We all wish good luck and best wishes for him. My question to you, I have come across one patient, that lady, her hemoglobin is too low, somewhere near 7, and the oxygen crunch is there somewhere that varies with the oxygen concentration up till 90, and otherwise it is 70 to varies between 70 to 80. She had essential thrombocythemia or thrombocytosis, whatever you call it. So my concern is that platelet is somewhere near more than 7 lakhs. And how should I handle this patient? As you already are aware about the bed condition, the oxygen condition, the crunch is going on. This is one case which I have come across. Second, patients are still showing after 28 days RT-PCR is positive and their CT values are somewhere near 27 to 30. They do ask how much the quarantine period, because in the previous first wave, government guidelines had come that after 14 to 18 or 20 days, you can be allowed to stop quarantine. How do we react? Whether this gentleman would emit the virus infection, or this gentleman has to remain still quarantined till the RT-PCR is negative. Your comments on to Dr. Nidhi and on to you.
Sir, as for the quarantine, I think we should follow the guideline that it is 5 days after the last symptom without treatment, or 14 days from the first symptom, whichever is later. Because it is clearly documented that the RT-PCR is checking on the viral DNA, viral RNA. It's not really picking up the viral proteins. It is not really picking up the virus, replicating virus. So we can safely say that 14 days from the first symptom or 5 days from the last symptom without treatment. RT-PCR negativity should not be the criteria to release from isolation. As for the thrombocytosis, I think I would also need Meenakshi to come in on this, because this is something which is, I think, for an internist.
So the question on the isolation?
No, the question on thrombocytosis.
Thrombocytosis.
Is the patient on steroids?
I have put her on steroids.
Yeah,
she
so
was
the thing
taking
is
some
that
hydro. She was taking some hydro urea, something of that medicine. She is continuing alternate days, and she has long standing. I had put her on steroids, on aspirin.
So when the patient is on steroids, usually we do see the blood picture. There is a pancytosis actually. So once you start tapering off the steroids, probably the platelets will start decreasing. But and even the hemoglobin, that would be a matter of concern. You would have to see whether she would need an infusion or the cause, because there is she might be just rule out thalassemia major, or has that been ruled out?
That is not there.
Okay. So what is the cause of this very low hemoglobin? Have you been able to assess that?
I have not gone on that details, because I want that she should be stabilized and she should be admitted and she should be given right kind of treatment. My concern is whether aspirin or low molecular weight heparin or NOACs, are these indicated or they are not indicated in these conditions? Together, my question is again together, aspirin with NOACs.
Should be given or not? Is that the question? I'm sorry, you got cut off.
That should be given or not? This is what I want to say.
Yes, it should be given. In my
It should
opinion,
be
that the
given.
in my opinion,
Okay.
it should be given. Yes.
Okay, the opinion of vascular specialist might be required, or
Right.
hematologist is required. Again, the second question regarding the blood sugar levels, as Dr. K.K. Agrawal has said, it put on Novonorm. Can
Right.
if patient is already taking metformin or other SUs, shall that be continued, or SGLT2 or DPP4, or straight away to insulin?
Novonorm would be in addition to whatever. Excuse me. No,
Metformin would continue.
no, yeah, Novonorm would always be in addition to the metformin and whatever oral hypoglycemics are already going on, because
Okay.
this is to compensate the increase in sugar levels due to the steroids and the
Understandable.
COVID condition itself.
If
So
still not
yeah.
controlled, go on to basal, bolus, or premix, or prandial, or any kind of insulin accordingly.
Yeah, so even I am facing this problem. A lot of people are not being able to get a good control in spite of giving Novonorm. So I am moving them to insulin actrapid, and if
Actrapid,
required,
actrapid,
yeah, yeah,
3 times in a day.
with yeah, three
Titration
times
3
in a
times.
day. Instead of Novonorm, I'm using that in the cases where there is no not good control with Novonorm. I'm
Actrapid
moving
comes
them to
with the
insulin.
name Actrapid, or Humalog it comes regular?
It comes with the name actrapid, insulin actrapid. I'm giving that to them, and 3 times a day, and the units is decided based on the sliding scale.
Okay. Okay.
Yeah.
Sir, how long has she had this thrombocytosis? Dr. Israni?
Dr. Israni, Dr. Israni.
Yes, yes. For I think more than 2 years, they were saying. This lady is around 70 years of age.
So because platelets are otherwise an acute phase reactant, so maybe, I mean, they need to figure that out. 2 years is a long time for an acute phase reactant to be high. And usually the trigger for platelets would be an acute infection or even a bleeding episode. So maybe she's having an ongoing bleed somewhere.
Maybe
That's why her
possibly.
hemoglobin is also low. So that's something that can be investigated.
But they are on, this lady is on hydrouria. Some medicine I have not heard about it. Hydrouria alternate days. I would be going in detail. Let her this condition, oxygen crunch condition, should be stabilized.
Yes, yes.
I think she's on hydroxyurea, is it?
Yes.
Okay. That's a antineoplastic. So you'll have to see me, because there might be. So in that case, anyway, blood thinners and steroids are not contraindicated. So you can go ahead with that, and you can find out. And so we are following the protocol that if a person, this is a cancer patient or something like that, we are always asking them to consult
He
their
was
oncologist.
all the time he was saying that this lady was not leukemic, something of that sort. He was uttering.
Probably a better clinical history, yeah, you could have, and you can ask them, whoever is their treating physician, they should keep them in the loop while they are taking their COVID treatment. I think that's the best way to go forward.
Sure.
Yeah. Dr. Vandana, is there anything you'd like to say?
There are some people who have raised their hands.
I think there are patients, and the patients would be requested. So this is a request to all of the patients. This is the DMA NDB and IMA meet. So I would request you to please take your questions to the other parallel OPD that we have running, and let the questions be taken by the doctors in this particular session. The link has been provided in the chat box. Is Dr. Kalra here? I think Dr. Kalra is also not here.
Have any of you seen post-vaccine breakthrough COVIDs? That would be an interesting thing to discuss right now, because we are seeing a lot of it in our clinics. Could you please put it in the chat box if any of you have seen post-vaccine breakthrough COVID?
I think everyone can unmute themselves. So if there's anyone who would like to talk about breakthrough COVID after the vaccine.
To my understanding, post 2 vaccine, If at all, I am seeing patients, but they are milder form. What is your opinion, Dr. Nidhi?
Can I
What is
share
your
two
gut
cases?
Number of cases I have come across, I am seeing patient post 2 vaccines. Post first vaccine, it's a common occurrence. But post 2 vaccine, I have been seeing, but they are the milder forms.
Sir, I think what I am observing is that it really depends on when the breakthrough COVID is happening. So if it is happening more than 1 month after the second dose, you are right, it is milder. However, if it is happening either after the first dose or after the within the week of the second dose, it is pretty severe. And as sir pointed out in the last meet also, this might be antibody dependent disease enhancement that we see in dengue also. So we have to be very careful. And if people are going in for their second vaccination, we should ask them to get their antibody titers done. If the antibodies are sufficient for the time being, it would be fine to hold back because the surge is there and we would like people to stay safe. If the antibodies are insufficient, then absolutely don't go for vaccination right now, because the insufficient antibodies cause the virus to be actually collected by the platelet as the presenting cell and enhances the disease process.
Can I share two cases, please?
Yes, ma'am.
I want to share my own experience with the COVID, if you want to.
Yes, sir. Yes, sir. You can take turns, whoever wants to go first.
I'm
Okay,
Dr. Sharma.
Ma'am, I have some very important question.
Let Dr. Sharma, he's pretty senior, let him share first and then we'll come to your question.
And then Dr. Kapoor after that.
Yeah, Dr.
I had
Kapoor
my second dose of vaccine on 23rd of Feb. On March, I got my antibodies tested. They were around 36. My CRP was 0.6. But on 8th of April, I developed severe myalgia along with fever, loss of smell also. And on 8th day, when I was feeling I'm recovering, suddenly I felt there was no cough, nothing. I just felt while taking steam, I can't have full breath. I got my HRCT done. It was 11/25.
That's accelerated.
And I'm a case of hypertension along with thrombocytopenia. My platelets were 49,000. And there was no cough. So that's what I realized. One of the finding is that if you can't have a long breath, that's one of the finding that you might be suffering from pneumonia, viral pneumonia. So that's one finding I want to tell that. And loss of smell and taste is not a guarantee that you won't have a moderate or severe this thing, pneumonia. Because two of my patients, one developed 5/25 HRCT score, another I have to admit because he was very bad. And both had loss of taste and loss of smell. So these 2 points I want to make, that loss of smell and taste is not a guarantee. And number two, that I had vaccine, I had moderate disease, plus cough is not important. This one of the finding which I noticed, take a slow, long breath. If you can't have a long breath, you might be having pneumonitis.
And sir, which vaccine was it that you took?
Covishield I took.
Covishield.
One in Jan, another in Feb.
So sir, what we are also observing is that the breakthrough, so it might be that you are now infected with the variant and that it is conferring its own immunity to you. However, I totally agree that today, even having no symptoms is no guarantee that you could not be having pneumonia. So we have to be very alert to the usual activity that we could do, whether we are able to carry on. like a deep breath. It's a very
Yeah.
good indicator.
It was a very good sign. That's what I noticed.
Yeah. Thank you for your input, sir. It's actually something that we should encourage. And sir says 6-minute walk test. I would say that even 1 minute, if you are not able to do what you were able to do earlier,
Yeah.
be
Doctor,
alert that there is something wrong.
My 6-minute walk was normal, always normal. Rather, it used to increase a bit.
So that's what I'm saying,
Dr.
sir.
Nidhi,
1 minute
Dr.
also.
Nidhi,
Yeah.
Dr.
Yeah.
Nidhi, as Dr. Sharma said it, he had second dose of vaccine that was on 23rd of February, he said, most probably.
Yeah.
That means 2 months have already been there.
Yes.
So how much time with your knowledge or whatever, we know very little about it, how much time, maybe 6 months or a year, the immunity, if at all, which has come, and antibodies he has formed, how much time the immunity would last?
Sir, as of now, we don't have any data on how long the immunity will last. Also, with every vaccination, there is a sort of success rate and an escape rate. With the present vaccines, the escape rate seems to be around 30%, which means 70% of those who get vaccinated will develop adequate immunity and 30% will not. So if you are in the unfortunate 30%, or if you are unfortunate to encounter a new strain, it's right now, we all have to assume that whatever atypical symptom we are getting could be COVID and be investigated. And I think we don't have to go for RT-PCR or CB-NATs. Just following our CBC and CRP can give us an enough indicator that we need to proceed further or not. I think Dr. Meenakshi can add to that.
And one more thing, Dr. The interchange of vaccine and subsequent the booster dosage later on, like Sputnik have come, about to come, and other Pfizer vaccines and other vaccines are about to come. Can that interchange would be allowed, or it would remain same category which we have already taken? What would be the future course of action?
Sir, in UK, they have done trials where they have tried to replace the second dose of AstraZeneca with Sputnik. And there is a logic to that. So AstraZeneca is a chimpanzee virus. It is a single strain. And when you do the next vaccine, the second dose, the antibodies will actually cancel it out also, even though there will be an immune memory, but there is an equal chance that it will be canceled out rather than enhancing. Whereas in Sputnik, it is a human adenovirus. There are 2 strains. So when you get vaccinated with one strain and you have loaded it with the viral spike protein DNA, with the second dose, the spike protein is the trigger, whereas the rest of the virus is not recognized as something that needs to be destroyed. So there is enhancement. So it is a good idea to wait for the results of the UK trial and see how they are going about it. And yes, it would make total sense to replace the second dose of AstraZeneca with Sputnik.
Can I share
And
my cases now?
Even the booster.
Even the booster, sir. Yes, it would totally make sense. It makes scientific sense to do so.
Dr. Nidhi, we have Dr. Kalra also with us now.
Yes, Dr. Kalra, good morning.
But Dr. Kapoor had some cases that she wanted to discuss.
Yeah.
So if you could take that before we...
I have 3-4 cases. Post-vaccination, 3rd day, just mild fever, took paracetamol, they were okay. On 6th day, they called me that we are having myalgia and totally loss of appetite and weakness. So I got their CRP done. All of them have more than 90, one 113, other one 112, other one the 98. So is this the indication for putting them on steroids and blood thinners?
It is definitely an indicator of investigating them further. Whether you put them on steroids immediately or after investigation will depend on the clinical picture. But as Dr. Sharma said, that his CT scan, despite having no symptoms, was pretty bad. Yes, giving a single dose of steroid to gain time and then investigating would be a good idea in this case.
One patient had CT score of 6/25.
Follow this patient.
This
Follow this
patient.
patient because
Okay.
6/25 is not a bad score. And sometimes they have an accelerated course. So our physician in our hospital had a score of 6/25 in the first CT, and then it rose to 16 within 3 days. So that's an accelerated course.
So yeah, if I may just add here that it depends on when you get the CT scan as well. If you've gotten it done in the earlier
on 6th day. No, 6th day.
Okay, but when did they spike a fever? Like when did they spike the fever? Because the fever is the surrogate. Yeah, so if they spike the fever on the 4th day, 6th day, the CT scan is showing 6/25. Expect this patient to worsen and observe him. If it is a high risk patient, you will already know. I mean, if he has comorbidities, if his age is too much, or
80 years.
Yeah, so then definitely I would personally start him on steroids and blood thinners. And in fact, I would monitor the CRP and the CBC, in fact, the lymphocytes. And if the patient is, the lymphocytes are showing a decreasing trend, then I would maybe even give them the full dose, 1 milligram per kg body weight until the CRP starts crashing.
I put them on methylprednisolone 16 twice a day. He's already on blood thinner, and CRP is now 10.
Dr. Kapoor, what happens is that, we make so that's what I'm coming to. When we make it a standard dose of 16 mg twice a day or 32 mg twice a day, we are not taking into account the weight of the patient. As Dr. Meenakshi just said, monitor it to the patient's actual weight. Make it even 1 milligram per kg body weight. We can deal with the outfall of steroid therapy, but we can't deal with the outfall of COVID that goes bad. So
what is the dose of deflazacort if at all you don't get methylprednisolone?
Deflazacort, yeah, deflazacort is a very mild steroid, and it has a very wide
therapy, and the efficacy is not good enough for COVID pneumonia. That's what we've seen. I mean, all the patients who have been on deflazacort, they have been coming to us in a deteriorating condition. They've that's our experience. But the equivalent dose, I'll just.
I think simple prednisolone.
I have a question for myself. Excuse me, I have a question for myself that after 6 weeks of first dose, I got COVID and mild COVID, and it became all right in a week's time. But now what should I do for the second dose? Should I get my antibody tested?
Yes, please. You should. And how long ago was your COVID recovery?
COVID recovery just now, just 1 week back.
No, ma'am, abhi nahi leni hai. You have to wait at least a month, get your antibody tested, and then see whether you would like your second dose. Sometimes you will find that your disease has become the second dose and you don't need the second dose. But this is still an evolving area of knowledge. We should get the antibodies tested before we go for the second dose.
Which vaccine? The level of antibodies.
What vaccine did you take?
Covishield I took. What is the level of antibodies I should expect?
So which antibody test we should suggest? Because a lot of people, their labs are giving antibodies negative less than 1 and more than 1, as they say, good antibodies IgG form. Which and specific antibodies we should order?
S protein, the antibodies to the S protein, that's what we should ask for. But not many labs are doing it right now. Yeah, the S protein, but the not many labs are doing it. So we are, just asking them for IgG. There's Pathkind, I believe, who's doing the one, but it's not done widely. So probably we would have to settle with the IgG for now till the S protein test.
And even though they have, I'll just complete the antibody thing. I'll just complete the antibody thing, then I'll give the mic over to you.
What level we should be satisfied?
Ma'am, that's what I was coming to. That is what I was coming to, ma'am. The labs are giving these scales of less than 1, more than 1, less than 10, more than 10, or whatever. Whatever they are giving is the reference range, and 10 times that much is considered adequate as of now. So we still, again, I said it is evolving. And if they don't give us neutralizing or non-neutralizing, we cannot make a complete judgment. But till we get that, IgG to spike protein is what we need.
Ma'am, I just need a small piece of information. Ma'am, yesterday night, there was one case which was referred. Patient age was 55. She came with the SpO2 range at 5%, and she had no pulse. The screen was completely blank, and she was not even taken in because we didn't have beds at that time. Then I fought with the administration and I took the charge and उनको admit कराया हमने, but she was waiting for 2 hours already. When we took her, the screen, there was no pulse. उनकी पूरी extremities cold हो चुकी थी, पूरी body cold हो गई थी. We were not even getting the veins. We arranged मतलब बाई डबल वाला कैनुला एंड उनको नॉरेट चला दिया था 60 पे पर ड्रॉप लाइक आईवी फ्लो मीटर से. उनको एट्रोपिन दे दी 1 एम्प्यूल एंड हाइड्रोकॉर्ड भी दे दिया मैम. और तब भी पल्स वाज मतलब वी जस्ट केप्ट हर ऑब्जर्विंग. SpO2 के लिए हमने बेन सर्किट पे ले लिया था सेंट्रल लाइन से पेशेंट को. और मैम हमने ना प्रिकॉशनरी उनको डेक्सोना दे दी थी 8 mg in 100 ml NS. And उनका शुगर शूट होती थी, तो we managed it with at rapid 10 minutes instantly. Ma'am, I just have a question. क्या और हमने उनको inoxaparin दी थी 60 mg. Ma'am, can inoxaparin cause death in such patients? We revived her at 5 a.m. in the morning. We got her SpO2 at 90 again, and which was fluctuating anyhow. And उनका पल्स वी गॉट एट उनको CPR देना पड़ा बहुत. मतलब हमने आई थिंक 3-4 राउंड्स दिए थे CPR के. तो मैम वी गॉट हर पल्स बैक एट 140 इमीडिएटली. वी मतलब हमने नॉरेड हटा दिया फटाक से और उनको RL चला रखा था बिकॉज आई थॉट इट वाज हाइपोवोलेमिक कंडीशन. उनको पोजीशनिंग भी कर दी थी, लेग्स अपराइट कर दिए थे. और मैम इनॉक्सापैरिन दी थी. मैम आई जस्ट हैव अ क्वेश्चन. We lost her at 8 a.m. in the morning क्योंकि लाइट चली गई. गवर्नमेंट हॉस्पिटल था और हमारे पास कोई बैकअप नहीं था. पूरा सारे मॉनिटर्स बंद हो गए एंड we missed her in that 15 minutes of delay. मैम, is it true that enoxaparin की वजह से हुआ क्या ये?
Dr. Nidhi, you're mute.
First of all, very heroic effort. And I think you deserve full credit for that. अब वो enoxaparin से हुआ कि disease से हुआ, I don't think right now you should be beating yourself up for that. You should be satisfied that you did your part well. And if this was to happen, इसके beyond आप कुछ नहीं कर सकते थे. So this is something that we all should take to heart, that we do the best we can and we still lose some patients. It never becomes easy, and and I think kudos to you that you have still managed to come to this meet and share this with us. Take a little time to breathe and calm yourself, and don't blame yourself for anything.
Ma'am, I just want little guide. मतलब, do I suspect कि as her SpO2 was 5% and her pupils were already semi-dilated. तो मैम, do I suspect कि SpO2 ना मिलने की वजह से brain death पहले ही हो चुकी थी when she was in the cart in the waiting?
Possible, very possible.
It's not because of the enoxaparin, because she was 90% dead. तो हम तो जबरदस्ती we were doing it.
पूजा, मैंने तुम्हें अभी भी कहा कि don't question your judgment at that time. What you did is in the national guidelines. What you did is okay. She may already have been beyond recovery, and you made a very heroic effort. You got the pulse back. we are still debating on enoxaparin. In fact, before this meet started, Dr. Meenakshi, myself, and Saurabh, we were discussing only this. And this is not something that you should be beating yourself with.
Ma'am,
Dr.
I got
Kalra.
cases like that. But this is also
I think this is not due to drug. It is the disease itself, because it's known to affect the cardiac functions also. It is a multi-system involvement in the end. Patient initially may be responding, but later on, due to sepsis or whatever you say, due to the this all problem because of the COVID, maybe it was some cardiac involvement which led to this kind of a picture, and may not be because of the enoxaparin.
Can I
think
say something, Dr. Nidhi? Manisha
yes.
here, Dr.
Yeah.
Manisha. That's dear Pooja Sahni. Hold yourself, beta. That's all I'll say.
Yeah.
Hi, ma'am.
Hold yourself strong and nice. You have fought. यमराज से लड़ना आसान नहीं है.
Hi, ma'am.
हाँ, बिल्कुल शांत रहो. हमने बहुत डेथ्स देखी हैं और अब तुम जान लो. So brace yourself for tragedy, and you have fought with the tragedy very strongly, very bravely. So don't blame yourself. Don't think back. God is God. Yamraj is Yamraj. That's the conclusion. Don't ever question yourself on this. Okay? Thank you.
Harsh Bagchandani wants to say something. उसके बाद डॉक्टर जैन आप बोल लीजिएगा.
Ma'am, actually my father had tested positive on 22nd, and we then got a CRP test, 3 points on that scale. After got a CT scan done, it was 10 the CT score.
You're not very clear, Harsh. You're not very clear.
Hello. Hello.
Yes.
Ma'am, my father got tested back on 22nd. We got his reports done. His CRP score was 3 and his CT scan score was 10. But from the past 2-3 days, his oxygen level was coming down to 94, 95. And this morning, his oxygen level was 91. And he is also feeling some congestion in the chest. So, ma'am, what could be the next?
Get the CT scan repeated, get a CRP repeated, put him on steroids. And I think you should go to the clinic and get the prescription. Dr. Meenakshi, he can be sent to the...
Yes, for sure. You can, we are running a parallel OPD that's running from 10 o'clock to 10 o'clock in the night. And you can just go there and you can, there are a lot of doctors and a lot of COVID educators there who can help you out with your, with the prescriptions and what else you need. All right. So Dr. Kalra is here among us.
Dr. Nidhi, can I have your telephone number?
Yes, sir. I'll put it in the chat box, sir.
So I would just like to hand it over to Dr. Kalra to say a few words to sort of enlighten us about the current scenario if he has any input.
Yeah, we all know is unprecedented cases we are all facing, and real society needs real help. Nobody is aware what to do, and there are not enough professional or consultations available. So I think only now way left, as Dr. K.K. Agarwal has been doing for last so many days, we need to actually make aware the community empowerment, including all healthcare professionals and healthcare workers and community, so that, because as 80 to 85% of these all cases can be managed at home, only thing is to assessment. You just judge all the family members and yourself, which category you belong to, how much serious you are, and what is the possibility of progressing a disease in you or family members. And already the simplified government guidelines, as well as Dr. KK has been updating almost on daily basis some SOPs, protocols in case CRP is more than 10 or fever beyond 5th day is more than 101 and you are a high risk category, immediately start steroids and anticoagulations. So it is a timely actually monitoring, especially around day 3 to day 5. This time, the second wave, we see the pneumonia is coming very fast and in young age group. Earlier, the children and the younger age group were comparatively, they were had a mild disease and they were spared. But now this second wave, even children below 5 years, we are seeing patients and all youngster below 50 years, they are having very serious complications very early. So it's very important to make an assessment, assess yourself and other family members who are serious or non-serious accordingly as per the protocols available. I think protocol should be circulated to all the members attending this as well as even to the public also. This is a time now the public should understand and it should be empowered. If these criteria are there, this is the right thing which has been suggested. They should immediately start, even the need prescription are there. And if they need, they can talk to their own physician and discuss. Okay, this is what has been suggested by Dr. K.K. Agarwal with the prescription. If they agree, immediately start without waiting. The reports may take some time nowadays. Clinically, the basis of clinical and other your assessment criteria. Immediately, don't delay the starting of steroids, especially of day 5 have passed and fever is more than 101. You are having cough or difficulty in breathing, immediately start steroids. Standard dose is, if we say prednisolone, it is the standard adult dose is 40 milligram or equivalent doses of any other steroid preparation can be started along with anticoagulation. And monitor your every 48 to 72 hours with the hemogram, especially the lymphocyte count, the platelet counts, CRP, D-dimer, and if required, if you are having difficulty in breathing, or CT scan if required, definitely it's also, and monitor your SpO2, and if it's falling, the proning position is very, very important. Everybody should understand the benefit of prone positioning. Even in prone position for 30 minutes to 2 hours can save life. It can increase the oxygenation from 2 to 4%. It's very important. Everyone should know what is proning position. Means lying on your abdomen for half hour to 2 hours, then frequent changing the position. Then one left lateral position for half hour or 1 hour, then right lateral position, then sitting up, propping up for half an hour to 1 hour, and again back to prone position. It's very, this proning position is very important. And also yesterday we were discussing in the round table the use of ambu bag. Like nowadays, oxygen is real. We are seeing that we are losing people in the hospital. Even doctors are also, we are lost because of lack of availability of oxygen. So simple device, ambu bag, use of ambu bag, it can be a lifesaver. Like every family has now SpO2 monitor at the home for monitoring. Same way, I think this ambu bag should also be available at every family or in the society, which is on a sharing basis. And in case of emergency, when there is no concentrator available, no oxygen supply available, and somebody needs oxygenation, this atmospheric air, delivery of atmospheric air by ambu bag, for even the family members can do it for 2 to 3 hours at a stretch. That can be a life saving. So there's a need for empowerment of everybody. And I really appreciate the way healthcare professionals are working so with dedication and long hours. And no doubt, many of them we are seeing, they are also getting infected. So next time, now in a few days time, there will be very shortage of healthcare professionals. Then who is going to treat? It is a self-empowerment. It is through the society, through our associations and groups, and you all are medical professionals. You can make aware, educate the public what to do in case of emergency. Thank you.
Hello, doctor.
Yeah.
Doctor, good morning.
Yeah, good morning.
Dr. Nidhi, unmute. Dr.
Yeah, I said, rightly said, sir, that we need now the population also to be empowered and asking the right questions. But at the same time, I think we need to send this message out that please trust your doctor. If they're saying steroid is needed, take the steroid rather than questioning it. If they're saying that you need admission, trust them. If they just trust whoever is treating you, because we are all in this together and doing the best we can.
Hi, ma'am. Can I ask a question? Sorry, I'm interrupting in between.
No.
Actually, I was a COVID patient. I developed my symptoms on the April 15th. Today comes the 18th day, but yesterday night I'm okay. The fever went off in 1 day only. Then I took total isolation, multivitamins, AZ 500, SOS for Dolo 650. But yesterday night I felt shortness of breath, and my SpO2 comes between 95 to 99. It didn't go down anytime, but then I felt shortness of breath yesterday night. I took some proning exercise. I took green tea. Then I was able to sleep. But today I'm feeling heaviness on my chest, and I have this like a little cough and cold also. So it is, yeah.
So as Dr. Sharma's case pointed out, that we should not be ignoring anything.
Yes.
So do get your CRP tested. Do check out whether your effort on breathing and your oxygen saturation are good, and take a call accordingly.
Okay.
Hello, ma'am.
Hello, ma'am.
This is Pratik Goyal from.
Hello.
So I'm sorry, we won't be able to open it to the patients at the moment. Dr. Israni, would you like to say the final words for today?
So nice of you. Thank you very much for inviting me and giving me opportunity to close the session. Wonderful session which we have. We definitely miss Dr. K.K. Agarwal here, and you have done your job. My compliments to you, and the wonderful cases and wonderful scenario we had come across, and every time we have been making ourselves more and more intelligent, and at least we are capable thinking of ourselves as capable to handle the situations of COVID, which is really a burning situation and concern to all of us. My compliments and good wishes to all of you, and for everybody to be courageous and taking the cases in a definitely positive intentions and positive forms. God is there to help everybody. Thank you very much. I'm closing this
How is
session.
Dr.
On to you.
Agarwal? Sorry.
Dr. Ishran, Dr. Meenakshi.
Yes, ma'am. We'll just take your case. 1 second. Let us just close the live. Saurabh sir, can we close the live? Ritu?